Hi everyone, this is Mr. Neil Writer, also known as the Wax Whisperer. Thank you for tuning into my latest video. It's of a patient who attended with bilateral, fully occluded, impacted earwax. We're just commencing in the left ear. The entrance of both ears is somewhat narrow and collapsed. The cartilaginous portion, which makes up the outer third of the ear canal, as we age, that cartilage can lose its structure, its strength, and as it weakens, it can droop and collapse due to gravity. So quite often in elderly clients, we find that the entrance can be somewhat narrow. Once you're in the inner 2/3 of the ear canal, the bony part of the ear canal, that can hold its shape still. So just can make the procedure a bit more difficult because when the ears are narrow, there's less space in the ear canal. However, with an endoscope, we're able to stretch open the narrow entrance and gain access quite comfortably. The patient has been pre-oiling the ear to soften the wax. So sometimes you can run the risk of over softening the wax, and the wax becomes very stodgy and wet and sticky, and it can block the suction probe. However, in this case, although on a couple of occasions it did block the suction probe, the wax was coming out in big chunks. The patient did also have quite a few skin adhesions that were enveloped around the plug of wax. You can just see the technique there. When I train my clear wax delegates, in the case of the left ear, there's two techniques of entering the ear. The first one, I call it the tragus technique, and that's where we follow the instrument with the endoscope. So the instrument enters the ear first. We use the instrument to push back the posterior cartilaginous concha cartilage, which is where the suction probe is here. We just lift the cartilage up, and we can then enter slowly with the endoscope, always ensuring the suction probe is in view. There's also another technique when the ear canal is very, very narrow and collapsed, where we can stretch open the cartilage using the endoscope, similar to how we perform the procedure in the right ear. Eardrum's nice and healthy, good light reflex, ear canal's squeaky clean. Just in the right ear, and again, the entrance quite narrow, just using the endoscope to stretch open the posterior concha cartilage. So the concha cartilage is the cartilage, the outer part where the satellite dish portion of the ear canal is, and it's also forms the outer part of the ear canal, and the posterior is the back part of the ear canal. So we insert the endoscope, we push the cartilage, in the case of the right, to the left, which stretches open the ear canal, and it doesn't matter how narrow that ear canal is. Once you've stretched it open with the endoscope, you can gain access in any ear. We then enter safely with the suction probe or the instrument of use. You can see the keratin to the dead skin. It's just coating this plug of wax. It's a bit more stodgy and mushy on this side. You can see the few cilia, the hairs there, which form part of the outer ear canal. So on a couple of occasions, as I'm bringing out this impacted wax out of the entrance, because the entrance is quite narrow, the plug of wax got trapped at the entrance and it split into two. So just like there, so we brought the plug out, half the wax got dissected and trapped at the entrance, so just going back in there. An interesting landmark in this patient's ear is, you'll see at the end, mid-canal, on the posterior canal wall, so the back part of the ear canal, you'll see a slight bony protrusion. It's probably just an anatomical landmark that the patient was born with. It's not going to cause any problems at all. Sometimes you can get a condition called exotosis, also known as swimmer's ear. If you're exposed to cold water or cold winds, the inner two parts of the ear canal, the bony part, the periosteum bone, in response to cold, the blood vessels dilate, which causes bony spurs developing. And sometimes these bony spurs to surface ear can be quite pronounced, where it obstructs and constricts the ear canal completely, whereby sound can't enter. So it's plausible that this is a bit of exotosis, or the patient could just be born with it. Exotosis, normally you get 3 protrusions, one more at 12 o'clock and one at, say, 3, 4 o'clock, and the other at kind of more 9 o'clock. The patient's only got one here, eardrum's intact.